Your presenter today is Dr. Michael Sinnott, Senior Clinician and Innovator with ClickSmart. His expertise led him to become involved in the development of safety guidelines and legislation in the United States and safety standards here in Australia. In the commercial space, Michael is the co-founder of ClickSmart Proprietary Limited and SmartStream Proprietary Limited, who innovate and commercialise safety medical devices. Thank you so much for joining us today, Michael, and welcome to the microphone.
Let's now review the learning objectives for today. Firstly, to understand the risks and consequences of sharps injuries. Let me state the obvious. All sharp cuts and injuries are important but easy to ignore. What each one of us needs to remember is that every injury happens to a person just like you. This is unacceptable, yet we have somehow accepted it. So I'd like to congratulate you for taking the initiative to learn how to protect yourself by watching this webinar. Next, to examine the common reasons why staff safety can be neglected within healthcare facilities. One key question for each of us to ask ourselves is, why have we accepted working in an unsafe environment for so long? And then, are we going to do anything about it? Next, to review the current Australian regulations and standards that mandate sharp safety. This information is not normally part of a clinician's reading habits or curriculum, so I hope you will find it interesting and useful. Lastly, to explore sharps injury prevention strategies using the hierarchy of controls and apply them to clinical practice. The tools to make a difference are freely available, we just need to use them. I've added a personal action objective. This talk is designed to share information and insights with you on these topics as a way to both inspire you and arm you with what is needed to make the required changes in both your hospital and your own personal clinical practice. The agenda appears on this slide and will be repeated at the start of each section to help you follow the flow of the talk. Firstly, we will look at the consequences of sharps injuries for you, your patients, and your facility. Next, we will look at the costs involved in sharps injuries, and then the likelihood of an injury. We will then look at the reasons for which staff safety has been neglected. Towards the end, we will then look at the current relevant standards and regulations and how we can prevent sharps injuries using the hierarchy of controls. To date, media attention and resources have been heavily focused on preventing needle sticks. This has probably happened for two reasons. Firstly, the large volumes of needles used across most areas of healthcare, and secondly, in simple terms, the risk of infection to the affected staff member is proportional to the volume of blood involved in the sharps injury. However, Janine Jager, founder of the EpiNet data collection software, published the results of a study of the incidence of sharps injuries pre and 10 years post Bill Clinton's November 2000 Needle Stick Safety and Prevention Act. They found that while there has been a 31.6% reduction in sharps injuries across the hospital, there has been a 6.5% rise in injuries in the operating rooms. So today's talk will give extra focus to scalpel injuries, as they could be described as the hidden or forgotten sharps injury. Definitions are important even when they seem obvious. The CDC, which is the Center for Disease Control in Atlanta, Georgia, USA, defines a sharps injury as an injury that occurs when a medical sharp, for example, a needle or a scalpel, injures a healthcare worker, resulting in the skin being broken. So now that we have defined what a sharps injury is, let's start by reviewing what the consequences of a sharps injury are for you, your patients, and your facility. It is important to understand that sharps injuries affect all three parties described above. And under injuries to yourself, it should not be forgotten that these injuries also affect your family and loved ones. This small sample of healthcare staff whose stories are available on the internet include 3 nurses and 1 surgeon. They were all injured at work by a sharp, and they were all infected with either or both HIV and hepatitis C. Their lives were changed forever. I would like to focus on Karen Daly's story. It was my great pleasure to meet Karen Daly in the States at an ARN conference back in 2013. We had dinner one evening and she shared her story with me. I also co-presented a keynote address using narrative to bring safety innovation to life with Karen and Sharon McNamara. Sharon is an ex-ARN president. The presentation occurred the following year in Chicago. Karen's story was both sad and inspiring. Karen was working a weekend shift at triage in the emergency department of a Boston hospital in Massachusetts back in 1998. By the end of her 12-hour shift, she was tired and could only think about going home. A nursing colleague was having trouble drawing blood from a patient, so Karen stepped in to help. During the process, she stuck herself with the needle. She was exhausted and all she wanted to do was go home. But her colleague, who now felt very guilty, insisted Karen report the incident and have the blood tests and follow-up. To cut a long story short, Karen seroconverted with both HIV and hepatitis C. This happened 6 months after the sharps injury. The next 12 months were very traumatic. Drug side effects, mental anguish about her unknown future, and disruption to family life, etc. The last month was the worst. She told me that the estimated cost of her drug treatment was well over $1 million. After she recovered, Karen went to great lengths to protect her colleagues from suffering a similar fate. She was a co-author of the Needle Stick Safety and Prevention Act, signed into law by Bill Clinton in November 2000. Karen also completed a PhD. It was a qualitative study based around interviews with 12 nurses who had suffered a sharps injury but were not infected. Karen told me that she remembered some of the nurses broke down and cried, even though it was years since the injury. They all suffered from self-blame. She described one case of a scalpel injury in more detail. Mavis was the scrub nurse in a case on a known HIV patient. She was cut with the used scalpel blade. One of her friends blurted out, "Mavis, what did you just do?" In retrospect, her colleague was probably saying, "Mavis, if it was your fault and not an accident, then I am safe and it won't happen to me." Mavis told Karen that after her injury, she was shunned by her friends. Let's look at a more recent case. This scalpel injury to a nurse was reported in 2019. It happened in Kurdistan, highlighting that we are talking about a global problem to which no one is immune, no matter how much we deny the risk. A 24-year-old nurse had a scalpel injury while removing the scalpel blade with artery forceps. The blade cut the medial aspect of her right wrist, resulting in a total transection of the ulnar artery. The nurse required an immediate procedure to ligate the artery. It took 2 years for the nurse to fully recover. This is a reminder that scalpels are designed to cut human tissue. It is worth noting that even though it was not explicitly stated, a 2-year recovery timeframe suggests to me a considerable mental health injury may have accompanied the physical injury. Hopefully these case studies have highlighted that none of us are immune from Sharps injuries or the consequences of Sharps injuries. So now let us look in more detail at the consequences of Sharps injuries, and let's look at it from 3 different perspectives. First, the staff's perspective, you and I. Many years ago, I was working with a number of young UK doctors in ED. They told me the story of one of their colleagues who was an intern in England when she suffered a needle stick injury. The injury was uncomplicated, but due to the psychological trauma, she never worked again. The subsequent suit cost the UK government a lot of money. Now, assuming your injury requires time off work to heal, we are lucky in Australia that we would be paid about 85% of our salary by workers' comp to cover the lost income while recovering. This is a great system, but it still means your income is down by 15% and possibly a lot more if your shift allowances and overtime are not covered. Worse still, you may be forced to change your career if you become infected. I know that in strict circumstances, surgeons can continue to operate, but only if their patients are happy to sign a consent form, acknowledging that the surgeon is, for example, HIV positive, and that there is a risk that the patient could become infected as well. I assume there are similar rules for nursing staff. Despite this possibility, most people find it too hard and move into different roles. Thirdly, again in Australia, a lot of the costs of surgery and medications are subsidised, but not 100% covered, and costs of getting to and from appointments, etc., can build up over a few months of rehabilitation. I remember hearing a number of stories about the early days of AIDS in the USA. Staff who were devastated when their blood tests confirmed that they had seroconverted to HIV after a Sharps injury were then told by their hospitals that they were of unsavoury character and that they probably caught the infection outside their hospital work and as such would not be covered. People often look at me in disbelief when I recount this story. It would never happen in Australia. And that is probably true. Even in the early days, the Australian response was much more balanced and protective of our injured staff. They say it would never happen today. I'm not so sure about this. We still have a widespread reluctance to invest in your safety and to confirm that any moves in this direction are actually seen through to the end. People do strange things when money is involved. The cost to the patient is often overlooked, despite them suffering a real, tangible harm when a staff member suffers a Sharps injury. For example, imagine you are the neurosurgical scrub sister. You get a scalpel cut, you go to ED to get blood tests, etc. Your patient's surgery is delayed if not cancelled. If you cut a digital nerve, you are out of action for several months. How long does it take for a colleague to be trained up to your expertise in neurosurgery and familiarity with the surgeon? How many patients' operations are delayed or cancelled? Not only is the patient's operation delayed or cancelled, the patient also has to be tested for HIV, hepatitis B, and hepatitis C to better determine the risks and management for the injured staff member. My understanding is that to take a blood test from a patient without their express permission is considered assault. So we are getting permission in this case, but it should not be underestimated the effect of these extra blood tests on the patient. Finally, we always worry about the doctor or the nurse catching HIV from the patient, but an infected staff member bleeding, say into an open abdominal wound, can just as easily infect the patient. Last but not least, the institution is also affected. Social costs include high staff turnover, poor morale, etc. It is estimated that the cost of losing a highly skilled staff member is up to the equivalent of 12 months of their salary. Treatment costs can be significant, so can the cost of an uncomplicated cut. Lawsuits are uncommon in Australia, but that may not always be the case. The largest suit in the USA was for over $10 million when a female intern was infected with HIV after suffering a needle stick injury in the ICU. She later died of AIDS. Workers' comp premiums are affected by the number of injuries and claims that are made. Investigating and following up a sharps injury has its own set of administrative costs. Hospital executives and accountants are easily lulled into a false sense of security that a sharps injury to a staff member does not cost them money. The problem is that the cost of the injury is not captured in one spot, as the costs are spread across many departments. The injured staff member's home ward, the ED where the initial assessment and workup is conducted, and the infectious disease unit where follow-up occurs, to name the most obvious ones. The danger here is that hospital executives and accountants, unaware of the cost of an injury, can't justify the cost of safety equipment because they can't measure or even estimate the savings. I'm not so sure how different this is to refusing to pay for the costs of the injury once it has occurred. As a result, you work under unnecessarily dangerous conditions. So now that we have looked at the consequences of sharps injuries to staff, patients and the hospitals, let's now look at the cost of these injuries. For the purpose of today's talk, I am going to create an artificial difference between an uncomplicated cut and a complicated injury to highlight a couple of important points. Uncomplicated scalpel cuts are a big inconvenience and an even bigger financial deal. The costs are estimated to be between $440 and over $4,000 for each cut. The difference in cost is a direct consequence of the research methodology used. In particular, what costs are included and which ones are excluded. For example, do we measure the immediate and follow-up blood tests only, or do we add in post-exposure prophylaxis and nursing or medical time lost while in the ED and attending other subsequent follow-up? In preparing for this talk, I was quite surprised to learn that the total cost of the uncomplicated cuts for most hospitals is much higher than the cost of complicated injuries. This is due to the difference in frequency of the two and the fact that treatment costs of HIV AIDS has reduced relative to the early days of that epidemic. For decades, we would ask nursing staff and hospital management, do you have many scalpel cuts? Only to be told quite emphatically, no, we don't have any scalpel injuries. The worst case I can remember is a first-hand story at a hospital in Queensland when the charge nurse told me, we don't have any scalpel cuts in our operating theatre. Only stupid people get cut, and let's face it, they deserve to get cut. This was a one-off story, and maybe the person was having a bad day. In retrospect, I wonder if staff might have been dismissing a scalpel cut as being minor and inconsequential, not a real injury. Just part of the job, easy to ignore. We think this might have added to the reluctance of the healthcare staff to report sharps injuries. In the past, this has been up to 50 to 70% of all sharps injuries being unreported. Fortunately, over the last 3 to 5 years, the response to our question, have you had many scalpel cuts in your operating theatre, has changed. It has become much more honest, with people willing to recount injuries to themselves and their colleagues. Our colleague in the States has been told by at least 3 nurses that they have each contracted hepatitis C from a past sharps injury. Complicated sharps injuries caused by scalpel blades fall into 2 broad categories. The first being physical injury. This is not surprising when you consider scalpels are designed to cut through body tissue. An injury to a digital artery, nerve or tendon, or a combination of these, results in the need for microsurgery and around 3 months of daily rehabilitation to regain normal hand function, which is critical for work and activities of normal daily living. Blood-borne infections make up the second big group. Over 20 such infections are recorded in the literature and include, as well as the big three, syphilis and herpes. The cost of treatment for hepatitis C is in the vicinity of 80 to 100,000 Australian dollars. I remember as a young ED registrar, one of my medical registrar colleagues got quite sick and eventually had to stop work completely. At the time, we heard rumours that she had been diagnosed with hepatitis non-A, non-B, which in retrospect was almost certainly hepatitis C from a Sharps injury. Real people are affected. This slide summarises the cost-benefit of injury prevention in this simplified image of an iceberg. Everyone knows how much safety equipment costs, but no one seems to take into consideration how much money, pain and suffering can be saved if injuries are prevented. Does this picture ring true to what you see happening in your hospital? Decisions are made on only half the information, the half that says the hospitals can't afford to invest in your safety. We at ClickSmart have developed a value analysis calculator to explain this more clearly. This free tool uses your own hospital data, and when this is unknown, it uses reference data from published articles to calculate both the cost of the safety equipment and its effectiveness, as well as to estimate the cost of the potential savings by using engineering controls to reduce injuries. A hospital-specific report is produced that can make it easier to convince management that your safety is worth investing in and can be afforded. It will be discussed in another upcoming CPD talk. However, if you would like to see it earlier, please contact me. Let me recap. We know what can happen if a staff member has a Sharps injury, and we know how much this can cost the staff member, the patient, and the hospital itself. Now let's quickly review the literature and see how likely these cuts and injuries are. Recent data shows 18,000 Sharps injuries occur to Australian healthcare workers every year, and this figure could be closer to 40,000 when you correct for the underreporting rate. What other industries tolerate this sort of injury rates? None. So why do we? In 2013, the Public Citizen published a report, Healthcare Workers Unprotected. Insufficient inspections and standards leave safety risks unaddressed. The Public Citizen is a US non-profit consumer advocacy organization. Their research found that certain healthcare workers suffered up to 4 times more musculoskeletal injuries than other industries, including agriculture and construction, and that healthcare workers suffered 7 times more assaults and acts of violence than overall private sector workplaces did. They described healthcare as a high hazard workplace. So I ask again, why do we tolerate this? We'll examine some of the reasons for this a little bit later. A large teaching hospital in Queensland recently published their findings of the number of injuries averaged over a 3-year period caused by different Sharps devices as a proportion of the number of devices purchased. They found that scalpel injury rates were 12.6 per 100,000 scalpels purchased. This was second only to 31.9 suture injuries per 100,000 purchases and over 4 times more than the 2.7 injuries with needles and syringes per 100,000 purchases. The importance of this research is that it is promoting the use of purchase data as a surrogate marker of device use. This gives a much more accurate benchmark for comparing the results of Sharps injury prevention initiatives, both over time within one hospital and across different hospitals at the same time. Prevention of scalpel injuries and suture needle injuries need to be taken more seriously, and the fact that the number of departments that use these Sharps is very limited should make it easier to successfully focus attention on them. The risk of infection from a Sharps injury involving an infected patient is very high. The risk for HIV is 1 in 300. For hepatitis B, it is a staggering 1 in 3. That's Russian roulette odds, but fortunately this risk has been minimised with hospital-wide hepatitis B vaccination programs. However, hepatitis C has a risk that is also incredibly high at 1 in 30. Back in 1993, I did a 6-month term as the HIV registrar in Wattlebrae at the Royal Brisbane Hospital. HIV was then very much a fatal disease. Seroconversion, which often went unnoticed. 10 years later, AIDS defining illness. 4 years later, death. Fortunately, HIV is now an outpatient disease. Hepatitis B vaccine is highly effective in preventing infection, and all hospital staff should be immunised. Hepatitis C still does not have a vaccine, but a treatment is now available. However, it is very expensive, between $80,000 and $100,000 per patient treatment. I would like to suggest an interesting exercise for you to undertake. The next time you are talking to a new nurse grad or an intern, ask them what they think the risk of seroconversion from a positive patient is. The last time I did this, the answer ranged from 1 in 1,000 to 1 in tens of thousands. This slide shows the results of another study we did at the PA hospital, published back in 2008, and probably still accurate today. It shows 137 injuries reported, with 3 injuries occurring when loading the scalpel blade onto the handle. Even though you can't catch an infection at this stage, you can still suffer a physical injury. 24 occurred when passing, 65 or around 50% occurred during use, and at this stage these are probably not preventable. 18 when removing the blade, 14 during disposal, 7 during cleaning, and 6 injuries were experienced by downstream staff. This means that approximately 50% of scalpel cuts and injuries are preventable. It is worth noting that in most studies, including this one, 6 to 10% of all injuries occur to downstream staff, for example, wardies and laundry staff. And this can be even more stressful as they have no idea which patient's blood they have been exposed to. This also highlights the need to not only remove a scalpel or sharp safely, but the need to also contain it safely. This study also found by extrapolation that combining a single-handed scalpel blade remover with a hands-free passing technique was up to 5 times safer than the misnamed safety scalpel. Time for another recap. Sharps injuries, including scalpel cuts, do occur and actually occur fairly frequently, over 12 times for every 100,000 scalpels used. The consequence of these cuts and injuries can be minor or life-threatening. They can be both physical and psychological, and they all cost money. Bills paid by staff, by patients, and the hospitals themselves. So as I asked earlier, why has staff safety been neglected? There are a range of organisational factors that have inhibited staff safety issues being addressed. Today, I'm going to focus on what our hospital team of researchers have observed and published, namely a small number of reasons why staff don't take their own safety seriously. We are going to concentrate on the first 3, the ones that each of us has some control over. These reasons should not be misinterpreted as putting the blame on you, but they do highlight areas where we need to expand our thinking. Firstly, denial. We now know that the risk of contracting HIV from an infected patient is 1 in 300, and for hepatitis C it is 1 in 30. But we all somehow know that the infection will happen to someone else, not to me personally. In the early 1990s, I was a medical registrar working in Wattlebrae, the ward in which we treated all of our HIV patients. One of our nurses refused to wear gloves because she did not want her patients to think they were being treated differently. The inevitable happened, She had a needle stick. I remember seeing her go as pale as a ghost. In fact, she had to take 3 days sick leave due to the stress. Fortunately, she did not become infected. To me, this parallels what we see when 19-year-old boys drive cars too fast and while intoxicated, because they think they are immortal. We are guilty of the same thinking when we take unnecessary risks, like using fingers to remove used scalpel blades or not wearing gloves when taking blood. Second is our willingness as clinicians to take unnecessary risks with our own safety. Would you agree with our observation that if you take a risk for your patient, you are somehow a better person? Putting our patients first reinforces our identity, the reasons we got into our caring professions in the first place. But remember, the risks we are taking now are much more serious than they were 40 years ago, pre-AIDS. And when you take that risk, your children do too. In this cartoon, we see a child crying, not sick and definitely not dying. The man on the right rushes across hot coals in bare feet, almost certainly injuring himself badly. The lady on the left is smarter. She knows that the child is only crying, so she puts on her shoes before she walks across the coals to console the child. Finally, and most worryingly, is that when we are injured, we all too often blame ourselves. This in part explains why 50% of all sharps injuries go unreported, and it also means that after an injury, we don't look at ways to prevent it recurring. A couple of years ago, I looked after 2 of our registrars who suffered sharps injuries only a few weeks apart. The first one looked at me a bit embarrassed and said to me, "It was my fault, I wasn't concentrating," meaning he would never have another injury because he would never lose concentration again. This is an impossibility, especially in a hectic ED. The other registrar told me it was her fault because she was rushed. Now, if the staff blame themselves after they suffer a sharps injury, they are too embarrassed to report the injury. If they don't report it, nothing happens to prevent the next injury to themselves or their colleagues. How can we expect management to respond if they don't even know that the injuries are happening? How can we expect them to do something about it? Much more recently, a nurse in short stay came up to me after she had been deliberately kicked in the chest by a tox patient. The first words out of her mouth were, "It was my fault. I should have been expecting it." Now, the reason I find this self-blame phenomenon so concerning is that it flies in the face of our understanding of how to improve patient safety. A quick summary. In 1999, the "To Err is Human" report was published. It found that there were up to 100,000 avoidable deaths in US hospitals every year. Research found equivalent results in Australia and many other countries. People like the British psychologist James Reason noted that doctors and nurses don't go to work with the aim of hurting patients. This led to the idea of systems failures and the concept of the Swiss cheese model. The world slowly swung into action to improve safety by promoting the adoption of no blame culture for patient safety. Sadly, staff safety has been in large part ignored, with you and I continuing to believe that taking a risk with our own safety for the benefit of our patients is acceptable, if not laudable. We still all too often blame ourselves when we are injured. We have this split mindset, no blame culture for patient safety, but self-blame culture for staff safety. Even blind Freddie can tell you that this dichotomy can't solve anything. The information I have shared with you thus far today is all a bit daunting. So let's change tack and look at what can be done to make our workplaces safer. To start with, let's look at the rules and regulations that are already in place to protect you. This information should be useful when you start campaigning for staff safety in your institution. This Australian New Zealand standard was published in 1998. This simple diagrammatic summary of the standard is not rocket science. It says, don't use fingers, artery forceps, or dangerous resheathing or two-handed devices. I still hear stories of 4 out of 10 nurses still occasionally using fingers to remove used scalpel blades. Sadly, I have to admit that if I was in a hurry, I might be guilty of doing this too. Guilty of taking a shortcut, a bit like driving through a flooded road. An update of this standard is coming soon. It should be published later this year or first up in 2021. We will arrange to let you know when it is available for you to share with the powers to be in your hospital. According to Queensland Health, we are all duty holders for health, safety and well-being, and so the law is applicable to each of us. Under the Act, the Department of Health and the HHSs have a duty of care to manage risks by eliminating health and safety risks so far as is reasonably practical, and if it is not reasonably practical to do so, to minimise those risks. Our executive officers must exercise due diligence to ensure the Department of Health and the HHSs comply with their legal duty to manage risks. Our executive officers include the Director General, the Deputy Director General, Chief Executive Officers, HHS board members, and Health Service Chief Executives. The same principles apply to private hospitals. So when you decide to make a change to the safety of your workplace, the law is on your side. The National Safety and Quality Health Service Standards have been written by the Australian Commission on Safety and Quality in Healthcare. They are reviewed by the Australian Council on Healthcare Standards during hospital accreditations. They refer to the Australian Guidelines for Prevention and Control of Infections, authored by the National Health and Medical Research Council, which says healthcare facilities should have SHARPS safety programs, which include consideration of notifiable incidents. So again, when you decide to make a change to the safety of your workplace, the hospital accreditation process is also on your side. We at ClickSmart have been advocating in Australia and internationally to have hospital accreditation processes place more emphasis on measuring staff safety in addition to measuring patient safety. We have even developed a staff safety scorecard to facilitate this. In this, the last section, we are going to go through the evidence-based prevention strategies using the hierarchy of controls, which will assist you to align your clinical practice with the relevant safety standards and regulations. The hierarchy of controls dates back to 1950, when they were developed by the National Safety Council in America. They took an upside-down approach to the behaviour-based safety programs that ignored hazards and risks and focused on critical workers' behaviour. The old way of looking at safety relied heavily on elaborate mechanisms to check, inspect, observe, coach, reward, and discipline workers. NIOSH used this language informally in 1986 in relation to occupational lung diseases, but the real focus was not introduced until 2007. On the left, you can see the hierarchy of controls published by NIOSH, which in simple terms is a research and education institution aligned closely with the CDC, Centre for Disease Control. On the other hand, OSHA, Occupational Health and Safety Administration, was created to enforce the legislation. They describe 5 levels: elimination, substitution, engineering controls, administrative controls, and PPE. On the right-hand side, Queensland Health has combined the 5 steps into 3 levels. I will go into the practical interpretation of these three levels in the next few slides. Before I do, I would like to draw your attention to the fact that in both of the above diagrams, PPE sits at the bottom. It is the least effective way of preventing sharps injuries. The least effective way of preventing injuries. It protects the wearer, but does not make the overall environment safer. It can give the wearer a false sense of security, yet it is getting all the attention in the popular media, and I and a number of other colleagues are now concerned this focus on PPE may distract attention and budgets away from the more effective engineering controls, counterintuitively making your workplaces less safe. Level 1 revolves around elimination of the hazard. This is obviously the best way of reducing injuries when it is a possibility. For example, eliminating unnecessary injections or introducing needle-free intravenous access systems. However, lots of times elimination of a sharp is not physically possible. For example, the need for scalpels to make the incision to create access for the surgeon, unless of course you believe in psychic surgery. Level 2 controls include substitution, isolation, and engineering controls. Examples of substitution include blunt-tipped suture needles designed for use with certain tissues like muscle and fascia. Examples of engineering controls include spring-loaded safety syringes, single-handed scalpel blade removers, safety scalpels, and sharp spins. Let's look at how to choose the best type of safety device. The original work on prevention of sharps injuries after the Clinton legislation referred to ESIPSs, Engineered Sharps Injury Protection Devices. Karen Daly told me that this was a concession made by the lawmakers to the manufacturers. It was much less disruptive to their manufacturing lines to add a safety feature than to start from scratch and actually make a safer device. The underlying hypothesis was that if the safety feature was attached to the original device, it would be safer. On the surface, this looks reasonable, but I can find no evidence that this is the case in any industry. I'm sure there may be some examples, but I was unable to find any. My reasoning now would be that a device that is attached to the safety feature would be more convenient to use, but there is no proof that this translates into safety for the user. On one of my early visits to the CDC in Atlanta, I was told about an interesting study that they had funded. Researchers went into several hospitals, collected their sharp spins, sterilized the contents with gamma radiation, and then opened them and inspected a particular phlebotomy device with an active safety feature. That is, you had to press a button to activate the safety feature. They found that in one hospital, only 17% of these much more expensive safety devices were activated. In other hospitals, the activation rates were 27, 67, and 90%. This is why it is so important to determine if your safety device is a passive or automatic safety device as opposed to an active or manual safety device. More recent studies are confirming what you would expect. Passive safety devices are superior. In one study, passive safety devices were only involved in an injury rate of 0.06 injuries per 100,000 devices purchased, compared to 4.24 injuries with active safety devices per 100,000 purchased, a factor of 70. Let's look at some examples. The safest safety syringes are spring-loaded retractable syringes, passive safety, which have automatic retraction of the sharp into the syringe after the plunger is pushed to the end of the barrel, on the left side of the left-hand diagram. The devices requiring a sheath to be manually pushed over the end of the needle at the completion of the procedure are known as active safety devices. They are much more prone to be involved in an injury, as it is a form of recapping and thus compared to be less safe. The active safety syringe in this picture is an example of what I was referring to earlier. It was very cheap and fast to add this little sheath here on the bottom to the side of the standard syringe to comply with the new legislation. However, if you look at this closer, this is very dangerous practice. You have to use a finger to push the sheath over the needle, over the exposed needle, a bit like the band recapping procedure. It's easy to see what will happen if the reuser is distracted, even if only for a second. From a practical point of view, the passive safety devices are usually single-handed, whereas the active safety devices usually require both hands to operate. Early research indicated that the misnamed safety scalpel actually caused 2 to 4 times more injuries than the standard metal scalpel handle with no safety features. Fuente's paper used the activation rates to extrapolate that a single-handed blade remover combined with a hands-free passing technique could prevent up to 5 times more injuries than a safety scalpel. Level 3 covers both administrative action and personal protective equipment. Hepatitis B vaccines obviously make a huge difference to your safety, but it doesn't in any shape or form reduce the risk of injury and the risk of being infected with HIV or hepatitis C or any of the other 20 bloodborne pathogens. Training is an important part of the overall safety program, but without engineering controls, it has at best a short-term effect. Training also needs to occur when engineering devices are implemented and periodically after that. Double gloving in theory prevents the risk of seroconversion by reducing the risk of blood affecting the wound, and protective footwear makes sense. However, I would like to return to the history of the hierarchy of controls. Concentrating on PPE is aimed at reviewing critical workers' behaviour rather than focusing on the environmental hazards and risks. Hopefully this talk has encouraged you to stand up for your own safety and given you the tools to implement the necessary changes. I would like to finish with a couple of positive stories. First, the staff at the Hunter, New England region combined an education program with strict engineering controls, in this case by mandating the use of spring-loaded safety syringes for all subcutaneous and intramuscular injections. Notably, they also ordered the use of these safety syringes and they removed all of the conventional syringes. They reduced the needle stick injury rate by 50%. In 2019, the World Health Organization held their first Global Patient Safety Day in over 150 countries. As a result of my prior research and advocacy efforts in developing a culture of staff safety in healthcare and recognizing its direct impact on patient safety, I was invited to give a keynote address in Malaysia. My presentation was about the importance of staff safety and its relationship to patient safety. A couple of weeks ago, I read with some pride that the WHO's theme for 2021 is Health Worker Safety, a priority for patient safety. Their first 2 goals are 1, preventing sharps injuries, and 2, reducing work-related stress and burnout. My challenge to you is to decide what you can do in your facility to improve your sharps safety program and prevent sharps injuries, including the forgotten scalpel injuries. Sharps injuries are not your fault, but you are responsible for advocating for the necessary changes to reduce your risk of injury. If you don't do it, no one else will. You now have a very extensive understanding of the problem, the facts and the figures. You also have workplace health and safety law, accreditation standards, and WHO initiatives, plus common sense on your side. To work with management to make your workplace safer for you, your colleagues, your patients, and the hospital itself. Good luck. And remember, myself and our team are always happy to support you with more education and advice as you advocate for staff safety. You can also contact us directly to actually start using the recommended safety devices to reduce your risk of scalpel cuts and injuries. Thank you for your attendance.